Hello, everyone. My name is Jacques Tabacof. I am a hematologist at Centro Paulista de Oncologia, Grupo Oncoclínicas in São Paulo. And we are very happy to have Dr. Jorge Castillo, which works at Dana-Farber. He's, in fact, the clinical director of the BIMS Center for Waldenström Macroglobulinemia. And today we'll be discussing some information of the last ASH meeting that was in San Diego. Hi, Jorge, how are you doing?
Hi, I'm very well. Thank you for the kind invitation to talk about this interesting abstract.
Right. So the SYMPATICO trial was presented as a late-breaking abstract in the last day of ASH. And I think it was interesting because it was a suggestion of bringing venetoclax to the salvage for the second line or third line of mantle cell lymphoma in combination with ibrutinib, showed to be superior to ibrutinib. So I think in Brazil and many places, Bruton tyrosine kinases are frequently used in the relapsed setting of mantle cell lymphoma. Right? Do you agree? Of the SHINE study that tried to use venetoclax in first line, didn't pick up. What do you think about in front line?
Yeah, no, I agree. I think as we have seen in patients with chronic lymphocytic leukemia, right, and as well in mantle cell lymphoma, it seems to me that this combination is of interest. Whenever we try to see, the efficacy of any type of combination in the clinic, we always have to think about, what is really preclinical, right? That can actually understand the biology of how these medications do work. So I think the main impetus of making this combination work for most malignancies is because we do see a synergistic effect whenever we looked at laboratory studies, when we looked at cell lines or even primary cells of patients with CLL, with mantle cell, how they do synergistically, kill more cells as a combination that they will do independently. So I think it's very important to understand this biology. Now, the reasons, why in the frontline setting it has not been taken, much into consideration, is a lot of practices, or maybe the nature of the studies that have been done. But this study per se, the SYMPATICO study, looking at the relapse setting, I think it's an important aspect that you said earlier.
Yeah. So the study was a randomized study presented by Dr. Wang from MD Anderson, right? And it's 267 patients, relapsed mantle cell, never exposed to ibrutinib in the past. So they were randomized between ibrutinib plus venetoclax or ibrutinib placebo. 134 patients each arm, was well balanced, 68-year-old median age, 17% 3 lines or more, TP53 mutation in about 30% of the patients. So common population and balance in this kind of study, right?
Yeah, I do agree with that. I mean, obviously, one of the major downsides of any clinical trial, and I'm speaking as a clinical trialist, is that the patients in clinical trials are just a little bit different, right? Than the patients that we see in our clinics normally. Patients in clinical trials tend to be younger, tend to be stronger, tend to have better, social support and social networks. Right, there's just a little bit difference in number. More importantly, they want to be in the clinical trial, right? That's why they're there. So I think it's important that the clinical trial, at least, some of the clinical features of the patients do mimic what we see in the clinic. So from all the features that you mentioned, the one that I think it was important to me is to see that 96% of the patients had an ECOG 0 to 1. I mean, patients were in fantastic physical shape, right? And to begin this treatment. So that's an important aspect to also look into when we read these type of studies.
So this was a positive study. The PFS, the median PFS for the experimental arm the one of venetoclax plus ibrutinib was superior to ibrutinib placebo. And the median PFS was almost 32 months versus 22 months. There was a hazard ratio of 0.65. I think it was statistically significant and probably clinical significant. What do you think it's a...
Yeah, no, I agree. I mean, I think when we think about mantle cell lymphoma, right, we still classify it as an indolent lymphoma, but, you know, clinically speaking, we know that it's not really that indolent, right? It could be aggressive. Most patients with mantle cell lymphoma will die from mantle cell lymphoma. So it's not the same, you know, shouldn't be in the same bucket as, let's say, lymphoplasmacytic lymphoma or CLL. I think mantle cell lymphoma is a different animal. And from that setting, I think providing patients with a PFS benefit, I think is really, really important because, you know, that's what's going to kill the patient, disease progression. So, you know, as you said, the median progression-free survival difference was about 10 months, you know, with the addition of venetoclax. The interesting part of the design, which I want to emphasize for the audience here, is that ibrutinib was given indefinitely in both arms, right? So it's not like we're giving ibrutinib venetoclax and then we're stopping therapy, you know, as we have been trying to do in CLL and in lymphoplasmacytic lymphoma. So this is venetoclax is a finite duration therapy, but ibrutinib is an indefinite duration therapy in both arms, right? So I think that's an important aspect to really have in mind as well, you know, for most patients, for most people looking at a study like this.
In terms of toxicity, the experimental arm of venetoclax was a little more neutropenia, more hematologic toxicity, but then nothing very unexpected. Do you agree?
Yeah, I agree. And I mean, not unexpected, right? I mean, we do know that venetoclax causes neutropenia and also other cytopenias. So I'm not surprised to see that difference. And this is precisely driven by venetoclax. On the other hand, I mean, hematologists and oncologists, we're very used to manage this type of side effects, right? We usually worry when there's something outside of the hematological toxicity, but in the situation in which it's mainly hematological toxicity, I think that's very manageable for most of us.
All right, I think to close up, I think I will have for the exact amount of time for the discussion. I believe this was an important study. I think it's clinically important. And I think it's one other option that physicians and patients might have in terms of treating a difficult disease like mantle cell lymphoma in the relapse setting.
I would agree with that. Thank you very much.
Thank you.